Okay, and the meeting has started for recording purposes. I am now letting everybody in from the lobby. Good morning, everybody. As usual, it does take a minute or two for everyone to come in from the lobby. And so in the meanwhile, my name's Dominic Zerlo, and I'm with the Department of Health. And we are here as the Department of Health to help support this meeting. This is the meeting of the Patient Qualification and Safety Committee with Ian Dunn as the chair. Just as a reminder, we are recording this meeting, so please remember to keep language in the background to appropriate language so that we can ensure we can post this video at a later date. That is also one of two reasons why we do not have video for everyone. And once I finish speaking, I will actually be turning my video off, is we want to ensure that everybody has enough broadband is the second reason, or I'm sorry, not broadband, but bandwidth to be able to remain in the meeting as much as possible. And what we've discovered, of course, is that because some areas of the state do not have as good as internet as some other areas, we want to always make sure that people are able to remain in the meeting as much as possible. And while sometimes they still end up dropping off due to that lack of internet or poor internet quality, we want to try to reduce that as much as possible. And so with that, I will turn it on over to Ian. Ian, and I will get that document posted in the chat for the clinical support framework.
Perfect. Thank you guys so much for coming. Today we are in the Patient Qualification and Safety Committee. Welcome. We will be going over a medication interactions. So I am happy to see a couple people from the prior meetings that can help out with that. And if we want to go ahead and begin, if you would like to raise your hand and introduce yourself, your area of expertise, and what brings you to the Patient Qualification and Safety Committee, that would be great.
Good morning, Dr. Vida. I've unmuted your microphone. Whenever you're ready, go ahead and unmute yourself.
Thank you so much. Good morning, everyone. I'm Dr. Lita Fatemi. I am an internal medicine physician. I was at UNM for a decade as an academic hospitalist. Now I'm in hospice, end of life, work with our patients in the community. And we also have our Conscious Physicians Psychedelics Academy. And again, these topics of the committee are just wonderful because as we're teaching our academy students who are healthcare professionals, this is one of the biggest topics we talk about is patient qualification, contraindications, medications. Glad to be here. Thank you so much for creating this platform.
Thank you. Next up is Alan. Alan, I've enabled your microphone. You may unmute yourself whenever you're ready.
Thank you. Good morning, everyone. Happy to be here. My name is Ellen Schimmels. I'm a psychiatric mental health nurse practitioner in Albuquerque. I'm also an Army veteran and a clinical professor at Emory University. I've been a psychiatric nurse now for about 30 years, about 20 years as a nurse practitioner. I have advanced training in many different trauma-focused psychotherapies, extensive experience in clinical education with a focus on trauma-informed, evidence-based, and ethically grounded care. Happy to be here and support and bring my knowledge to the group. Thank you.
Thank you, Alan. And just a friendly reminder at this point, if anyone else would like to speak, please go ahead and raise your hand on the Teams. That way I can go ahead and enable your microphone credentials. Since no one else is requesting to speak at this time, I'll pass it back to you, Ian.
Alrighty, Jorge. So we will begin discussion on medication interactions. If you could pull up the document for me. So this is a list of basic medication interactions that I've found. So if there is any, ones that are missing, I am not perfect. We can definitely add those. So you are going to see some familiar ones. Ones we've already talked about are lithium, MAOIs, and stimulant use. This also goes a little bit broader into ones that aren't going to be blocked from participation, but are going to could dampen the psychedelic effects. And so I know in the dosage committee they were talking about or they adopted other dosages. So like maybe someone on these medications could need a substantially higher dose. And then there's also other drugs that increase the seizure threshold and that potentiate serotonergic effects. So there's a couple in here. We'll go ahead and start with the first one that we haven't already adopted, which is going to be atypical antipsychotics. So current main concern with psilocybin, they're likely to block psychedelic effects through 5-HT2A receptor antagonism. Tier 2, we want to get them extra clinical support, a risk mitigation plan, maybe get them that other dose or higher dose if they were not going to taper off. But should definitely be recognized as something that needs extra consideration. Is there any comments or discussion on atypical antipsychotics? All right, seeing none, we can go ahead and go on to SSRIs S/SNRIs. Their best supported issue is blunted subjective and possible therapeutic effect. So they as well may require a higher dose. Again, medication review, see if they need extra safety implementation if they are going to get a higher dose, not necessarily restricted. Just kind of a warning. Anyone have any questions, comments, concerns, or discussion on SSRIs or SNRIs? All right, now we'll move to tricyclic antidepressants. So it's just, again, a possible serotonergic caution. Interaction risk is limited, but the provider should still know and a safety plan should be in place. It should be tier 2, not very restricted, but again, just there as extra precaution. Any questions, comments, concerns, or discussion on tricyclic antidepressants? Seeing none, we'll go on to other serotonergic antidepressants. These are going to be trazodone, vilazodone, vortiroxetine, and other serotonergic antidepressants. They have a possible attenuation of psychedelic effects and serotonergic interaction concerns. These aren't very well established. So again, it's just a clinical warning, not anything restrictive. Any questions, comments, concerns on other serotonergic antidepressants? Cool. And then next we have bupropion. It is not primarily serotonergic. There's less evidence for blunting, but it can lower the seizure threshold. So caution is reasonable. Again, tier 2 is just having them make a safety plan and make sure that they are all, that we take extra time to review what is going on with their medications. So tier 2, I will again open for discussion, questions, comments, concerns. Ellen?
Alan, I've enabled your microphone. Go ahead.
Hey, sorry, I wasn't quick enough on the jump. I put it in the chat, but so I guess with the trazodone list, I would probably include mirtazapine and even buspirone. They're not necessary. I mean, for as far as serotonergic agents that we should be maybe aware of on that tier 2. I don't know if you were trying to lift. I know you're saying others, but I mean, they're probably they're more common than vilazodone or vortioxetine. So mirtazapine and buspirone. Thanks.
Thank you,
Perfect.
Alan. James, I've enabled your microphone. You're able to unmute yourself whenever you're ready.
Morning, everyone, and Ian, thanks again for chairing this committee. Going back to that, I do agree with the mirtazapine. On the Wellbutrin or bupropion, there's a mixed bag on that with the evidence that shows because of that regulation receptor, that it actually does a different mechanism. It's considered a DNAR. And so with the DNARs, they're necessarily used, maybe not an interaction. So I don't know if it needs to go there. That was just my thought on, the pharmacy side of it. Again, I think the mirtazapine is a great addition. I just think we just more discussion on the bupropion. I think we need. Thank you.
Yeah, and I definitely don't see bupropion as a like serotonergic issue. But I definitely the only reason it was really included as a warning is because it can lower seizure threshold. So caution would be reasonable, but I would definitely be open to more discussion on bupropion.
Alan, whenever you're ready, go ahead and unmute yourself, please.
Thanks again. Yeah, I also wanted to stay away from saying anything about serotonin with the bupropion because it's not a serotonergic agent. When we say lowers the seizure threshold, I can't remember where seizures are anyway, because one of the big things, the highest concern is like eating disorders, any kind of alcohol use with seizures and history of seizures, of course. So I feel like we're maybe addressing that already with where we put seizures in general on the other list outside the medication list, if that makes sense. So then we wouldn't be concerned about the bupropion, we'd be concerned about the potential for seizures if someone has a history of seizures or if they have, the alcohol or potential withdrawal or they have eating disorders. I guess it's like a chicken and the egg thing, but yeah, I would just take the serotonin, which you did out of there. Thanks.
All right, so I've updated the bupropion to just say can lower seizure threshold, so caution is reasonable. Is that what we're thinking, or would y'all prefer to just rather strike it completely?
Alan, go right ahead. Your microphone is enabled.
Sorry, I think again, if we could answer the question about what we are saying about anyone with a history of seizures and those types of things, because otherwise, I don't think you can blanketly say that without someone having the history. And if you look at a history of like seizure disorders or active eating disorders that could potentially lower that seizure threshold, which you're more concerned about, I guess that would already maybe negate someone from being, from being able to participate in the first place if it's active. You see what I'm saying? So it won't necessarily matter about the bupropion. And I'm just worried that if keeping bupropion would be like maybe a secondary level of defense. But I just don't want it I guess I worry about someone with, thinking that maybe bupropion is one of the safer agents because it doesn't have that serotonergic pathway would be a reason to maybe, yeah, get it off the list. Okay, you already did that. Sorry. Thanks.
No, you're good, you're good. I completely agree with what you're saying, and we already do have a history of seizure disorders under extra caution. So you're right. If that is our primary concern and the evidence is not as strong as with lithium, so I'm pretty okay with dismissing bupropion. Um, so next we had benzodiazepines. They just dampen the acute experience and may reduce therapeutic utility. They also are kind of used as a reversal agent, so chronic use of benzodiazepines may require an additional dose or other mechanisms. So I did say clinical support. Let's get a figure out what they need. Maybe they need a higher dosage. Maybe they need to taper off, whatever their provider decides. Um, but if they are on them at the time of administration, we do need to take that into consideration. How do y'all feel about that? Cool. And then cannabis has the potential to potentiate serotonergic effects. Again, not that it's dangerous, just that, hey, let's take another look at it, make sure that we're doing everything we can for these patients. Again, not a restriction, just let's pay attention. All right, and then are there any oh, sorry, Ellen.
I'm so sorry. And Ellen, go ahead whenever you're ready.
No, so I mean, obviously cannabis is also considered a medical. I just wonder if we should consider, I mean, I guess alcohol's already on our other list. I kind of think about cannabis and alcohol, even though it's obviously not in the same class by any means, I kind of think about that. Do we want to mention alcohol or anything like that here, or just keep with the cannabis because of the medical indications?
I only chose cannabis because of the fact that they're both serotonergic, but in theory, we could do alcohol as well. It may also dampen the acute experience and may reduce therapeutic utility. It has a lot of mechanism of action similarities with benzos. So we could add alcohol. Is that a common
Yeah,
sentiment?
I mean, that's what I was thinking, but if, again, I just off the top of my head can't remember, I mean, obviously acute intoxication would be I was already on our list, but I don't remember where else alcohol fell on the other side of the list. Not that, when we were talking about the
Like
THC,
history of use
right, with the
versus
history of it
like,
and stuff. Yeah, so it might already be covered. I don't want it to be redundant. Thanks.
yeah, so definitely will consider alcohol. Does anyone have any other medications or medication classes that I've missed? Anne?
And your microphone is enabled. Whenever you're ready, go ahead and unmute yourself, please.
Just in my work in Colorado, I've noticed that people on GLP-1s have had delayed onset, so potentially something to mention in there.
Thank you, Anne. Alan, I went ahead and enabled your microphone. Go ahead.
I know we have lithium listed specifically, but I don't know if we should also consider lamotrigine, another mood stabilizer, as that tier 2, just because of the same things. Like it's kind of known to blunt psychedelic effects as well. Thanks.
Thank you, Alan. James, I've enabled your microphone. Go ahead and unmute yourself whenever you're ready.
Thank you again. Just going back to that GLP-1, I think that's something to talk about and discuss, and it's something that in the literature it's coming very prevalent. This is something that we do need to kind of think about as a group. I think GLP-1s needs to be somewhere in here as a precautionary thing, or just like an FYI if you're on these, because there's so many people on them currently, and increasing in what we say numbers and concentration. There are a lot of more people coming. So thank you.
Thank you, James. Dr. Lida, I've enabled your microphone. Go ahead and unmute yourself whenever you're ready.
Yeah, to resonate with that, GLP-1s I've heard in the community where people are even just microdosing, for 4 days in a row, and they don't feel much. And then on the fourth day, when they're taking their GLP-1 at a higher dose and a microdose at a higher dose, then 4 hours later, they have a huge macrodose experience. So it's because of that lower GI motility that GLP-1s create. I totally agree that has to be considered. And maybe for 2 weeks, people shouldn't be really taking it before journey. The other medication group that I would be also advising, to look at is hormone replacement therapy, especially in females, perimenopause or menopausal females who are utilizing estrogen. That can enhance the effects because of serotonergic effects as well. But we have other experts here in the committee that can speak to that as well.
Thank you, Dr. Lida. Back to you.
Perfect. So I've added GLP-1s. The main concern that I've heard is the potential to delay onset. Is that the Am I getting that right, or is there more that I should say? Because I feel like the risk is more so that like because the onset is so delayed, maybe potential to significantly. Um, okay, and then the other one that we hadn't discussed as fully was the mood stabilizers. So how do we feel about lamotrigine and other mood stabilizers for psilocybin use?
Dr. Lida, your microphone is enabled. You may begin when you're ready. Dr. Lida, if you can hear us, we cannot hear you. Your microphone is enabled. So sorry, Dr. Lida, we still cannot hear you. If you're able to put it in the chat, that'll be applicable as well. And thank you, Dominic. Okay, she put it in the chat. Sorry, my phone isn't working. Understandable. If you're able to put it in the chat, please do so. And just a friendly reminder, as Dominic posted, the microphone button is what's utilized in the Teams app to mute or unmute yourself, or *6 from a telephone that's voice only. Ian, no one else has their hand up, so I'm going to send it back to you. Alan.
Ian, you're muted.
I'm so sorry. And Alan, your microphone is enabled. Go ahead and begin whenever you're ready.
Thanks. Now you're muting him. I don't know. I mean, I didn't necessarily mean to put mood stabilizers as a whole class because lamotrigine is the only one I've seen in literature that's actually linked to kind of muting that effect. I haven't, there should be no reason for valproic acid to do that, primarily because lamotrigine works on the glutamate system. But again, I mean, if we want to put it as a class, but put a lamotrigine as an example or something like that. But if we're doing like individual meds, I would probably lean on the side of just leaving the lamotrigine there as a tier 2. Thanks.
Perfect. So I went ahead and put lamotrigine since that is the one she specifically listed, as well as you right now. So they're likely to block psychedelic effect in tier 2. Ooh. And then are there any other medications that we still feel are missing? Alrighty, so why don't we go ahead and vote on the adoption of if I'm gonna give a little bit more time. Are y'all sure? Any other medications we should consider? Okay. Um, we will go ahead and vote on the adoption of this medication tier placement. All those in favor, please raise your hand. And I
Sorry, Ian,
believe
there's one, Dr. Lida has a comment in the chat. If you want to look at that before the vote.
yes, let's see. In regards, the concern is potentially dosing over the necessary effective dose and then having a major trip that was not expected. Likely. Okay, so I've gone ahead and updated it to GLP-1s, potential for significantly delayed onset. If additional dosing is provided due to the delay, the potential for overdosing is substantial. Ellen?
Ellen, I've went
I was
ahead
just
and
sorry, I
enabled
was just saying it, yeah, I was just saying it in the chat too, is maybe like we have likely for some of these and potential for some of these. Why don't we just use the same verbiage instead of using likely? I mean, I just think that maybe that's a stronger word for not necessarily a good reason. Thanks.
So I always used potential for what we have less documented information. So like atypical antipsychotics, we have very extensive documentation that they block the 5-HT2A receptor, which we believe is responsible for um, the psychedelic, or at least partially responsible for the psychedelic experience. So because of that, it is very likely, unless you are like everyone processes different medicine differently. So if you are the odd one out, maybe it doesn't for you. Whereas potential is we know the relationship between these, but we don't have as much evidence, if that
Well
makes
then,
sense.
oh sure. Then I guess for lamotrigine, I would say may instead of likely.
Okay.
And that's, I guess, for the antipsychotics, I understand likely is maybe a better verb for that, but just kind of, I was just trying to be
Okay.
mindful of the words. Thanks. I appreciate the
Yes.
explanation. That makes sense.
Yeah. So I changed lamotrigine to May. GLP-1s are still potential to significantly delay onset if additional dosing is provided due to the delay, the potential for overdosing is substantial.
But then if I could ask, when we say best supported issue is blunted subjective and possibly therapeutic effect under SSRIs, SNRIs, maybe there would be a way to make that a little clearer because
Mhm.
that thing.
So I could say it's blunted psychedelic effects. So what most people report is that almost it required a much higher dose to get the same results.
Right, right. And I appreciate that, but I guess the best supported issue, I don't understand that verbiage. Like why, let's maybe be consistent with what we're saying. So
Yeah, so
likely to say likely blunted psychedelic effect or something, because the best supported issue is just not how we worded anything else. That's, thank you.
likely blunted psychedelic effects, um, potential serotonergic caution interaction risk is limited, potential significant delay onset. Okay, I think this is good. May blunt, yeah, okay. Psychedelic effects. How about may potentiate? All right, any other comments, either in the chat or out loud? All right, seeing no comments, we can now move on to the medication interaction adoption. So at this time, if you are in support of adopting the current medication interactions as stand, please raise your hand.
I did six hands, Ian.
All right, you may put your hands down. And if you are against the adoption of the current medication interactions as they stand, please raise your hand.
I do not see any.
So with 6 yes and 0 no's, the motion is adopted. Which means we can get to our larger package. Because the work of this committee is almost done, we will go ahead and consolidate the recommendations into one document, which I should have as soon as SharePoint wants to load. All right, Jorge, the consolidated recommendations have been moved into the meeting folder. If you can just go ahead and open them for me.
Is that in today's folder for the 17th?
Yes.
Meetings. Okay. Aha, found it. Okay, you see that?
Yes,
Oh,
so
yeah, good.
these are the consolidated recommendations of everything that we have gone through so far as a committee. So if you want to scroll down to the initial qualifying conditions table, we're just going to review everything this committee has done and make sure we have not missed anything. So treatment-resistant depression, post-traumatic stress disorder, substance use disorders, and end-of-life distress are the 4 initial legislative qualifying conditions assigned to the ICD-10 codes on the right. And Metz has a comment.
I'm so
Great,
sorry about that,
thanks.
Ed. Go ahead.
No worries. It may be a little late to mention this, but after reviewing the original Hopkins studies on end-of-life distress, technically those people qualified for those studies because they had generalized anxiety disorder. And I'm just wondering about the alignment between, our desire to have Medicaid cover these treatments and having a Z code as the ICD-10. I wonder if it would be more useful to have generalized anxiety disorder as the ICD-10 code. I don't know, in addition to or in lieu of the Z code.
Yeah, and then actually, Dominic?
Yeah, thanks, Anne. That's a really great point. And just to let you know, the ICD-10 codes here are not necessarily what will be utilized with regard to billing. We actually are meeting with HCA. Actually, I have to look at my calendar, but here coming up soon, just to go over what potential billing codes are. So if the main concern on that is regarding billing, don't worry about that because we're going to be looking that over with HCA to sort of see what codes would be appropriate. And so we'll actually bring that to either this committee or as we just move forward, if we have permission, we'll just sort of adjust those codes to match what would work with HCA for the billing.
Yeah, these codes are largely for the Research and Continuous Improvement Committee, who are documenting, the effectiveness of these treatments and ensuring that we are doing things properly and we're getting as much data as we can to make sure we're making a safe program. So it's more internal, just saying here's what they roughly line up with so that we can track and ensure the program, but it doesn't have to do with billing. Ellen?
Ellen, go right ahead.
Thanks. On a similar vein, for post-traumatic stress disorder, I was just curious if we could use like the F43-1, like an X, because 1-2 implies that it's a chronic post-traumatic stress disorder, and there's no, I haven't read that there's any specific legislative condition that makes you have to have chronic PTSD versus an acute PTSD. And I might even err on the side of, if someone doesn't quite meet all the criteria, that they might even have an adjustment disorder. I don't know if that's, or if we don't want to make that distinguishing, that's fine. But I just at least would put an F43 dash or .1X, because that implies all of the PTSD diagnoses. Thanks.
Okay, perfect. And then Dr. Fatima?
Go right ahead.
Yeah, thank you. I was thinking, Dominic, if you guys want to also, when you talk to the HCA about prolonged service codes, it may be very appropriate to do so, because often these conversations go over the allotted expected time, and these codes cover that face-to-face time, and their utilization would be really beneficial for the practice that is, looking to sign up for this program. So just something to look into with them, maybe talk to them about the prolonged service codes. Thank you.
Thank you, Dr. Lida. Before I go ahead and enable your microphone, Lisa, just to catch up in the chat, Anne commented that adjustment disorder would be so helpful to have, and Alan concurs with that statement. Lisa, your microphone is enabled. Whenever you're ready, go right ahead.
Thank you. I was wondering if you guys would consider adding conditions like OCD, ADHD, and eating disorder to the list.
So these are just for internal translation of the legislative conditions to ICD-10 codes. At the moment, we are going to implement the program with these 4 conditions, ensure that these 4 have access before we create a huge patient demand that's going to cripple the new industry, because there won't be enough centers and growers and manufacturers to support them. So let's ensure that they have time to build up before we go ahead and endorse a bunch of new conditions, and then we have hundreds of thousands of patients who can't get care at all. Ellen?
Go ahead, Alan.
Thanks. Yes, and I appreciate that. I think we were, just to have it on the record, the adjustment disorder comment was really maybe not, meeting probably criteria for PTSD, but maybe not quite. And I think adjustment disorder could collectively be used instead of a Z code for end of life related distress, or even when you're looking at someone just being diagnosed with a medical illness that they would potentially die from, I guess, is part of that, not always knowing that the end of life is imminent, if that makes sense. I think that there's some, I don't even know. I know that they looked at GAD, as was mentioned earlier, but I think that would be really too stringent. But adjustment disorder kind of opens it up in a way that there's something going on that there's a significant adjustment too, and that's, I don't know if that, because that's where I think what is being said that would still fall under these buckets, but leave a little more, maybe a little more laxity for what it exactly is going on from the patient side. Things.
So we're thinking F43-2 for end of life distress? Please correct me if I'm wrong.
I mean, that's what I think, but I would also, I just think that that's maybe a better, a more collective way to capture that end of life distress in whatever context we're talking about.
I think I agree because I don't think end of life distress only happens when you're on palliative care. I think people can have that kind of distress even if, let's say, they had cancer, thought they were going to die, end up getting, their leg amputated, and they're still adjusting, but they still had that fear of end of life, and that still causes a bunch of existential distress. Um, so I could agree with adjustment disorder even outside of necessarily palliative care, but I do think that the majority should be what the legislators intended, which would be hospice and end of life care.
And if I don't, if actually, if you just take the X off of the, I think that will cover the PTSD now that I think about it too, because I didn't want to, I'm used to seeing the X's when we're implying like any of them, but just to take it off to make it cleaner. Thanks. And you just did. Appreciate it.
Thank you, Alan. Kate, I've enabled your microphone. Whenever you're ready, go ahead and unmute yourself, please.
Good morning, everybody. Yeah, this is Kate Hawk, and I'm closely involved with the End of Life Care Committee. Yeah, there is this question about, well, where do we start and how broad can this apply? And in the meeting, Senator Steinborn actually confirmed that they left end of life care or end of life open to be flexible. So right now, I think, this would be good to consider in our end of life care committee, but, there wasn't anything that said, well, this has to be hospice or this has to be palliative care. So just wanted to mention that. So maybe we can look at this further as we go.
Yeah, so I've already updated it to F43.2, which would be the adjustment disorder codes. Um, so I think that helps to really envision the end of life related distress because I don't think it only comes from like being in hospice. I think it can also come from just hearing that you have a serious diagnosis. Um, and if you're ever in the room with someone during that, it is a certain type of grief and end of life distress. And so I definitely would agree with that. I don't think they have to be in hospice care already. I think they definitely can get it to help them be more comfortable in those senses. Um, so is F43.2 okay with people?
I was just
Ellen?
wondering about the one that you removed. Would it work to have both?
Yeah, the palliative care Z code.
Yeah, I don't think we should remove that one. That one applies to.
All right, and Ellen?
Go ahead, Alan.
And thank you. I agree that we should keep the Z code there, but then I would also say let's look at the middle column and maybe take that palliative care status off. We can just say, just associated with or symptoms associated with serious or life-limiting illness. I think that would cover it well without just putting that palliative care label on, I think.
Thank you, Alan. And then just to catch up in the chat, Lori asked, does it have to be specific to end of life illness or could it just be older age? And Anne commented, that's fantastic. Wonderful adjustment. Thanks everyone for having such great ideas. Thank you.
Thank you all. So I have changed it to end of life distress with serious or life-limiting illness. And then kept the Z code Z51.5, added the adjustment disordered, Z code F43.2. Is everyone, any other comments? No? Okay, we can go ahead and move on to the clinical support framework. This is what we have been putting those medications into all day. Tier 1, proceed with standard protocol. Patient or provider may request additional clinical support, but it's patients without any Tier 2, 3, or Tier 4 criteria. Patients meeting criteria in this tier, for Tier 2, it's enhanced clinical support. They remain eligible for participation, but they need appropriate clinical consideration, which may include stabilization where appropriate and thoughtful support planning. The specific approach should be guided by practitioner judgment and the individual patient's clinical context. For Tier 2, required documentation is a risk mitigation plan to be available to the facilitator/administrator of psilocybin, a comprehensive medication review, and a documented monitoring plan. Tier 3 is specialist supported care. Patients meeting criteria in this tier may participate only with the required Tier 2 documentation and documented consultation and concurrence of 2 practitioner signatories prior to administration, the primary psilocybin practitioner responsible for the patient's care, and a licensed specialist practicing within their scope of licensure and possessing expertise relevant to the identified condition. So this could be a psychiatrist, a psychiatric mental health nurse practitioner, a cardiologist, a neurologist, or other appropriately credentialed clinician. And then Tier 4 is not appropriate for participation at this time. Any questions, comments, concerns on the actual framework? Cool. So now these are the clinical support framework criteria. So what is actually in each of these? So active eating disorder or significant malnutrition, taking more than or equal to a high intensity dose as defined by the Dosage Administration and Clinical Practices Committee. So they design that as being equal to above 50 milligrams of psilocybin. This would only usually be for patients, that are taking medication that may blunt their subjective effect and what they perceive and get out of psilocybin therapy. That's why it's here. Tier 3, specialist supported care, history of bipolar 2 disorders, history of delusional disorders, history of dissociative disorders. And then Tier 4, not appropriate at this time. So there's a couple situations if the individual is under the age of 18, if they are pregnant, if they are breastfeeding, unless the patient and provider implement and document a plan to pump and discard breast milk for at least 24 hours following administration. There are a couple of stabilization before treatment conditions. These mean we will accept them, but we do need them to be stabilized before they are appropriate. So this would be an active psychotic episode, a history of TIAs or CVAs, clinically significant uncontrolled hypertension, uncontrolled diabetes mellitus, uncontrolled seizure disorder, current suicidal or homicidal ideation with intent, plan, or inability to maintain safety. And then there are a couple of conditions that are contraindications to participation in psilocybin services. Those are going to be a history of schizophrenia spectrum disorders, a history of persistent or recurrent psychotic disorder, including psychosis precipitated by serotonergic psychedelic exposure, history of bipolar 1 disorder, history of borderline personality disorder, severe congestive heart failure, known allergy to psilocybin-containing mushrooms, and an active inability to provide informed consent. Everyone good with the criteria, or do you have any discussion on those?
Dr. Lita, your microphone is enabled. Go ahead.
Thank you. I would add coronary artery disease or just atherosclerotic, just heart disease in general. So just severe heart failure does not, does not cover all the cardiac disorders. And given that there's so many, there's a really large number of serotonin receptors in the heart muscle itself that people can go into a cardiac complication and even have a heart attack during a session with psilocybin. So I think that has to be a contraindication, cardiovascular disease.
Thank you,
Or
Dr. Lita.
at least be, yeah, education. Thank you.
Thank you, Dr. Lita. And Lori commented, Lori commented in the chat, why is borderline excluded? I feel it would help my patients with borderline. No?
There is not substantial evidence that it is helpful to borderline personality disorder, and there's some evidence that it may exacerbate mood swings and emotional instability, as well as splitting. So it typically is not used for borderline personality disorder. There is some emerging evidence about the use in bipolar 2 disorder, but I have not seen any on borderline personality disorder. All right, so just to clarify, we're adding coronary artery disease and cardiovascular disease. Anyone have any objections to that? Okay. Any other conditions you think we need to add?
And just in the chat, Ian, Lori commented, just because it's not shown to be helpful does not necessitate, exclusion.
No, it doesn't, but when it has been shown to cause harm, that does. It is a very high-risk tool to give someone with BPD because it can cause mood instability, and we don't want to be the ones responsible for causing that. But I do want to say this is not, how do I say, like, it's not the end all be all. As soon as more research comes out, which the Medical Psilocybin program is investing in, we will be able to see more information. And once we get more information, and maybe I'm completely off base and it turns out that borderline personality disorder is extremely helped by psilocybin. If that turns out to be the case, then we will adjust going forward and we would just strike it and add it as a qualifying condition if it is helpful. It's not the end all be all. I just wanted to remind you all of that. And then the medication interaction considerations that we talked about earlier, copied and pasted into this, so it is the exact same thing we talked about. And that is it. So this is what's up for adoption is our consolidated recommendations. With the additions that we have discussed, all those in favor, please raise your hand.
I do see 6 hands, 7.
Perfect. And you may put your hands down. Although, let me wait a little bit longer for those to. Um, all right, all those opposed?
I do not see any.
All right. So the consolidated recommendations are adopted, and that is what I had planned for y'all today. Does anyone else have any discussion or things that you would like to discuss or? Without anything, I guess we can go ahead and set the next meeting. So, hold on, let my calendar load. How does April 6th sound for everyone? Perfect.
What time?
Seeing
What time, Ian?
9 a.m.
Okay. I think that looks good on our end. Johnny? Yes, is that correct? Oh, is that correct?
Yeah, looks good. I think Dominic will be out of the office, but otherwise, I think that's good.
Yes, Johnny is correct, but the meetings can continue even though I'll be out. You all have this down. You're all doing this so very well, and so I am not necessary for the process, but I will review the video, of course, afterwards.
Well, thank you all for being here. I hope you have a wonderful rest of your day. Be safe out there, and I appreciate all of your input and for everyone taking the time to be here. I love the conversations, and thank you for supporting this program.
Thank you, everyone. Thank you, Ian.
Thank you, everybody. Have a great and wonderful week.